Welcome to the Controversies in Cardiology series. My name is Dr. Daniel Simon. I'm the president of the Harrington Heart and Vascular Institute at University Hospital's Case Medical Center. Today I'm joined by Dr. Jackson Wright, professor of medicine, Case Western Reserve University, director of the General Clinical Research Center, Case Western, and the clinical program director of our hypertension program. Welcome, Jackson.
Thank you. Good to be here.
Great. Well, today, Jackson, we're going to talk about the landmark sprint trial. We're so honored and privileged to have you with us today. Let me see if I can set the stage for our viewers.
Okay.
We know that there's a linear relationship between blood pressure and cardiovascular risk, at least down perhaps to 115. But we really don't know what the optimal blood pressure target is. Tell us, in light of that, set us up for the sprint trial. What was it testing and who was included?
Yeah. Well, first of all, clearly the question that you raised is right on the money. There has always been a question in terms of how low should blood pressure be lowered. The assumption is a blood pressure of 0 is a little unhealthy, but where above 0 is the optimal blood pressure. Even though the observational data would suggest that risk increases above 100, systolic blood pressure above 115, we really do not have or did not have the studies looking at lowering blood pressure much below 150. And that was a major controversy. In fact, if you remember, about a year and a half ago, there was one guideline panel recommended, in fact, that in patients over age 60, that rather than treating blood pressure down to systolic blood pressure down to less than 140, that in fact we should relax the blood pressure targets in those patients to less than 150. Even though there was a minority panel that recommended otherwise, that we should retain the 140 as a target. But the whole issue was because we did not have studies, good studies, adequately powered studies to evaluate lower blood pressures. And so that was the question. And so that was one of the reasons that in the late around 2008, 2009, the NHLBI decided to, in fact, initiate the SPRINT trial, the systolic blood pressure intervention trial.
So terrific. So you're one of the co-PIs of the trial, presented its landmark results at the National Scientific Meetings of the American Heart Association, simultaneously published in the New England Journal. So let's take our viewers through this step by step. Okay, so who was included in the trial and what was the intervention?
Yeah. Between November of 2010 and March of 2013, 9,361 patients were randomized at over 100 academic medical centers around the country. The study population, they were randomized to either a systolic blood pressure of less than 140 versus a lower target less than 120. The study population included, it was a very diverse study population. It included 30% African Americans. It included both men and women. 36% of the participants were women. It included patients with and without kidney disease. 28% of the patients had chronic kidney disease. It included patients with and without cardiovascular disease. 20% of the participants had evidence of cardiovascular disease, and also included patients. Over 28% of participants were, in fact, over age 75.
Yeah, so that's terrific. So it's a diverse population. Importantly, though, it excludes diabetic patients, patients with prior stroke.
Correct.
And about 60% of the patients had a Framingham risk score of over 15%. So these were patients at high risk for cardiovascular disease, right?
These were patients at relatively high cardiovascular risk. I mean, that's where you do the clinical trials. patients who do not have events, you can't look at you can't compare
Right.
treatment targets.
So baseline blood pressures. I think one of the things that surprised me in the study population was that really a third of the patients had a systolic pressure less than 132. A third had a systolic blood pressure that was, right around less than 140. It was only a third that were what we would say by our old standards were overtly hypertensive, although the inclusion criteria, I believe, was up to 180.
Yeah, well, don't forget that over 90% of the participants were on treatment. So that these were patients, most of these patients were on treatment, and the average blood pressure was, in fact, systolic blood pressure was 139.
Okay, great. So we start out with two groups. We're at 139. How many meds on average were they on at baseline?
At baseline, they were on about 1.8 medications
So
on average.
We randomize,
Right.
and then how good was the randomization? What did the blood pressures get to in each group?
Blood pressures, average blood pressures in those randomized to the standard group was 136. And it was those randomized to the intensive group, less than 120 group. Within a year, it got down to 121, and average blood pressure over the course of the study was about 121, 121.5 in the intensive group.
So terrific. So how many meds were required to get us down to 121?
On average, about one more medication was required in those treated to the less than 120 target compared to those treated to the less than 140 target. So that there was it required 1.8 medications in those in the less than 140 group, and 2.8 medications on average in those randomized to the less than 120 target.
Okay, so it's an open label trial. Tell
Open
us
label.
about how meds were decided. Obviously, you're the former chairman of the executive committee of All Hat, so I know you have your preferences and recommendations. How did the trial mandate medications? Was there an algorithm, start with diuretics, ACE inhibitors, channel blockers? How was that advised?
Medications were not mandated. It was recommended, and the protocol did encourage the use of medications that had been shown to prevent cardiovascular events in randomized clinical trials. So that would include the thiazide-type diuretics, the ACE inhibitors and ARBs, and the calcium channel blockers were the treatment classes that had been shown to be effective in preventing cardiovascular events. Beta blockers were encouraged in patients who had coronary disease, and either ACE inhibitors or ARBs were encouraged in patients with kidney disease.
Okay, terrific. So the real important question is, what was exactly the primary efficacy endpoint, and what were the safety endpoints that you pre-specified?
Yeah. The pre-specified primary outcome was the composite of coronary or MI, stroke, hospitalized heart failure, or patients with acute coronary syndrome, as well as cardiovascular mortality.
Great. So a good breadbasket of major adverse cardiovascular and cerebrovascular events. And then what about safety? Clearly, as you start getting to 3 meds, pressures that could be under 110, we're worried about what kind of safety endpoints?
There were intensive monitoring for safety endpoints in this study, particularly because of the fact that there were 28% of the participants were over age 75, and there was a major concern about whether or not the safety of the lower blood pressures in that target population. So that there were monitored, certainly looked for side effects that may be related to the blood pressure intervention, hypotension, obviously, syncope, falls, injurious falls, orthostatic hypotension were of major concern, as well as the hospitalizations, ER visits, particularly for for falls, et cetera. And these were monitored, as well as the other parameters that are looked at in
And of course, you were looking
trials.
very carefully at renal function, I'm sure.
We certainly looked at renal function. As I said, that would be one of the, in fact, there was, as I indicated, about 28% of the participants did have chronic kidney disease. And so that, and the major renal outcome in the trial was the 50% in patients with chronic kidney disease, a 50% decline in EGFR, dialysis, or transplantation.
Terrific. Okay, so we've set it up now. Everybody knows about the splash. You're a famous man across the United States. Tell us the top line results, Jackson. What were the top line results of the trial?
Yeah, I should mention that that the trial also, in addition to looking for cardiovascular events, in looking for renal outcomes, a major portion of the trial was also devoted to looking at the effect of the lower blood pressure target, or comparing the lower blood pressure target in cognition and incident dementia. That part of the trial is still ongoing. But with regards to the outcome, there was trial had planned to go between 4 and 6 years, median follow-up of about 5 years. In fact, we received a call August 20th that in fact the director of NHLBI had reviewed the report of the Trials Data Safety Monitoring Board and decided that the trial should be stopped at 3.26 years rather than 5 years of follow-up.
Right, so stopped early for overwhelming benefit, and tell us what that benefit was.
The benefit was essentially a 25% reduction in the primary outcome, cardiovascular outcome, which included a 38% reduction in heart failure, a 43% reduction in cardiovascular death, and amazingly a 27% reduction in all-cause mortality.
Yeah, so I mean, look, you design a trial trying to hit a double or a triple. This was clearly a home run. Congratulations on these amazing results. Now, a question I have for you as a cardiologist, I would have thought we would have seen perhaps a greater effect on myocardial infarction and possibly even stroke. Do you think that is a consequence of premature stopping of the trial because of benefit on the other endpoints? Or do you think somehow that this is a different population? Clear effects on new heart failure, almost a 40% reduction. What about heart attack and stroke?
Yeah, well, don't forget the point estimates for all of the outcomes was in fact on the correct side of the line of unity.
Absolutely.
And so that suggested benefit, even though there was, it did not reach statistical significance. So there was, I believe, if I remember right, an 11% reduction in MI.
Right.
There was an 11% reduction in stroke. Did not achieve statistical significance, but if you looked at the confidence intervals, they overlapped what you would anticipate, what has been seen in other studies.
Right. So from a magnitude of absolute reduction, number needed to treat of the primary endpoints, about 61 or so, is that correct?
61 at 3.26 years. Right. Obviously, it would probably go lower if it had gone through 5 years, but the trial didn't last that long. 90 was the number needed to treat to prevent a mortality, total mortality.
So a life-saving intervention, reducing the primary outcome. Okay, at what cost? So tell us about the safety endpoints.
Yeah, there was a, as expected, there was, well, first of all, overall, there was no significant difference in SAEs by treatment group. But there was, as expected, about a 1 to 2% increase in adverse events and SAEs in patients treated to the lower blood pressure target compared to those treated to the less than 140 standard blood pressure target. This would include orthostatic. This would include hypotension, as you would expect. There was about a 1 to 2% increase in syncope. There was no increase in injurious falls. And in fact, participants in the standard less than 140 target actually had significantly greater orthostatic hypotension than did those in the intensive group. And even more importantly is the fact that in the patient population over age 75, there was those patients had derived all of the benefit of the lower blood pressure target with regards to clinical outcomes, but also tolerated the lower blood pressure target at least as well as did those who were less than age 75.
Right. So really, it's a phenomenal result, and a lot of questions have come up, obviously, by practitioners. So let me start with a few. One is that this is a clinical trial setting. Patients are monitored carefully. How generalizable do you think this is to the population that was enrolled in the trial in the community? Were patients more carefully managed with respect to renal dysfunction, side effects of hypotension, orthostasis? Can you just give the drugs and say, see you in 6 months? Or is this tighter control that we have to be careful as we move out into the community?
Okay, why don't we back up just a little bit, because don't forget the objective of the trial was in fact to see whether treating to that lower blood pressure target provided benefit,
right,
and what are the risks of treating to that target. So that in doing that as part of a clinical trial, you have to pay attention to a lot of details.
Absolutely.
You have to see you do see the patients more frequently, and they are monitored more closely. Now the question becomes, how do we position this? Can this intervention be in fact utilized in clinical practice?
Yeah. So I think implementation is really the key issue. How do you go from clinical trial to implementation? Yeah. So let me ask you a question, though, which I think is puzzling to some people. The ACCORD trial tested 140 versus 120 in diabetic patients. And although I think in a nice companion editorial to your paper in the New England Journal, there was a sense that the point estimate, at least on the right side of Unity, did favor outcomes of a lower blood pressure in ACCORD, but it was a negative trial. Lead us through, as a nephrologist and a hypertension expert, are the ACCORD results similar to SPRINT, or is there a divergence that if you really have a diabetic, you need to be careful?
Yeah, that's a question that's often asked, and one of the issues we have to deal with is the fact that diabetics were excluded from SPRINT, as were patients with who had a stroke. Because of the fact, and patients with polycystic kidney disease, because of the fact there were trials that were either ongoing testing the interventions in those patient populations, or as with the ACCORD trial had just completed, and this was during the time that the SPRINT was being planned. So those patient populations were in fact excluded. In terms of comparing ACCORD and SPRINT, have to keep in mind that ACCORD was only half the size of SPRINT. So SPRINT had twice as many patients. The projected event rate in ACCORD was the observed event rate in ACCORD was only half of what it was predicted. So it was also underpowered.
Right.
And also as you mentioned, the point estimates are on the correct side of Unity. And there was about a 12% reduction in the primary outcome. Did not achieve statistical significance, but it was also much less power to see a significant difference. And if you looked at, again, the confidence intervals, it was every bit in ACCORD. For the primary outcome, it was about, it went out to about 27% benefit reduction, which corresponds, which is similar to what we saw in SPRINT.
Yeah. So I guess the real question now is, as we start thinking about generalizing these results to the non-clinical trial patient. Guidelines are going to become critical. Doctors are frankly confused. I mean, I have patients calling me up saying, Dan, you guys are like yo-yos. First you told me I could go up to 150. Now I see my Wall Street Journal, you're telling me I need to be 120. So what is it going to take for the guideline writers now to look at Sprint, look at Accord even perhaps, do meta-analysis and say, okay, this is what we recommend as a change? When do you think that, you're a guideline writer, you've been on many guideline writing committees. What do you think it's going to take?
Well, one, I think as an investigator, my job is to provide the data for the guideline committees and the provider community to digest, and then come to the adequate conclusion for the benefit of the patients. But I think the data from Sprint are fairly compelling and will have to be considered in guideline recommendations. And I'm certain that they will. I think in addition, it will be a challenge that we will have to accept in terms of how do we achieve the targets that are in fact that have been shown to provide significant and substantial benefit in patients. You talk about a 25% reduction in cardiovascular events, a 43% reduction in cardiovascular mortality, a 27% reduction in all-cause mortality. The numbers needed to treat, in fact, are even lower in patients over age 75. So we're talking about bringing in a brand new paradigm in terms of the management of hypertension.
No, I mean, this is incredibly impressive. And again, our nephrology and hypertension colleagues are outpacing cardiology in this arena.
And don't forget, I am not a nephrologist. I'm actually a clinical pharmacologist. So, but as such, I do both cardiovascular as well as nephrology trials, renal trials.
Okay, well, Jackson, thank you so much for coming by today for our Controversies in Cardiology session. I'd like to thank our viewers for watching Controversies in Cardiology, the landmark Sprint trial. See you soon.